Hello, everyone. My name is Dr. Neil Sharma. I'm the chair for the editorial board for iGIE. iGIE is the latest publication from the GIE, Elsevier, and ASGE family. Welcome, everyone, to another episode of the iGIE podcast. Thank you so much for tuning in. I think this will be a very exciting episode for all those of you who are interested in Barrett's esophagus. We have some very well-published authors who will be highlighting their most recent publication in iGIE. We had our premiere episode for iGIE Journal come out in December 2022, and we're highlighting one of the publications from that premiere episode. So without further ado, I'd like you to tune in to our iGIE podcast and get to hear from the authors themselves, Dr. Corbett, Dr. Oz, as well as Dr. Matt McKinley. Thank you.
Welcome to iGIE podcast. I appreciate everyone tuning in. We have yet another author interview from our premiere episode, our premiere journal of iGIE. My name is Neil Sharma, and I'm joined by three authors today who are going to talk to you about their publication in our premiere journal episode. Can you all introduce yourselves, please? Perhaps, Scott, you want to start first?
Sure. I'm Scott Corbett from Sarasota, Florida. I have specialized in interventional endoscopy since starting private practice in Sarasota in 1984. I've been the medical director of Suncoast Endoscopy, our ambulatory surgical center, where a lot of this work has been done, as well as being chief of gastroenterology at Sarasota Memorial Hospital in Sarasota, where a lot of our interventional stuff has been done. Thank you.
Hi, guys. I'm Robert Odds. I'm a GI pathologist. For about 30 years, I was the chief of GI pathology and professor of pathology at Harvard Medical School, Brigham and Women's Hospital. During that time, my predominant areas of research were in the areas of Barrett's esophagus and inflammatory bowel disease, and some other conditions of the GI tract. But the common theme was how cancers develop through inflammation, dysplasia, and carcinoma in the GI tract, of which, of course, one of the model areas is Barrett's esophagus. I'm now currently a consultant pathologist at Tufts Medical Center and Tufts Medical School, and I'm a professor of pathology there as well. I also run my own medical consulting business where I consult for the biotech industry and CRO industry and pharmaceutical industry. But all that is related to, my passion, which is, researching Barrett's esophagus and inflammatory bowel disease and how cancers develop through a progressive dysplasia carcinoma pathway.
And last but not least, Dr. McKinley.
Good. Hi, Neil. Thanks for having us. Even though this is not a young group, I'm going to claim to be the senior member of this group. Having started as an attending in 1980, so I've been doing GI for over 40 years. And my interests have been, just like Scott's, interventional endoscopy, although it was called, actually, we didn't call ourselves anything, but that was the beginning of advanced endoscopy in the 70s, 80s, and 90s. The first half of my career, I was chief of GI at North Shore University Hospital in Manhasset, New York. I started the fellowship there and spent almost 20 years running the fellowship. One of my main interests, besides doing ERCPs and other therapeutic procedures, was Barrett's esophagus. Screening, diagnosing, surveying Barrett's. And, I lived through the periods when we used fiber optic scopes. So it was commonplace for us to try new techniques using Lugol solution, various biopsy forceps. I don't know if Scott remembers, we actually had a biopsy forceps that went down the scope and made a left turn and hit the wall because it was difficult, with the old scopes and the old biopsy forceps to get an adequate forceps biopsy from the distal esophagus. We utilized over the years. Go ahead, Scott.
I said that old K-scope.
Yeah, that's right. That's right. We had oblique scopes. We had curved biopsy forceps, etc. And but I was fortunate enough when I was full-time at North Shore to have actually a flow cytometry lab. And so we dabbled in looking for aneuploidy and actually published significant data on early detection of neoplastic change, dysplasia, and then correlating it with aneuploidy. So I've been in the business for 40 years and always excited about using new techniques. There only have been a couple of breakthroughs that I can see it from the 50,000 mile perspective. That is the introduction of video endoscopy, narrowband imaging, and special stains, et cetera. Rob can tell you more about that. Kind of have come and gone. And then with WATS3d brushes, basically, that's been a real shaker and mover, allowing us to pick up, increase our sensitivity in trying to find early neoplastic change and act accordingly. And so, so I was delighted to be involved with these gentlemen and looking at the data that was provided to us and coming up with the conclusions.
Well, I'm lucky to be around the three of you. I really do enjoy having these types of author interviews, but particularly people who have great perspective on kind of where we've come from and potentially where we can go. So we'll focus on that a little bit, but why don't we jump first into a brief overview of the article? So maybe we can just start with, what's the article's title and name, and just 2-3 sentences about, the design of the article and how it's all set up.
Sure. Neil, our paper is the utility of WATS3d as an adjunct to forceps biopsies in surveillance of Barrett's patients post endoscopic eradication therapy. Okay, and since Matt's going back in time here, I'll go back in time a little bit too. And I think the first time I really got interested in Barrett's esophagus was in 1997 at the Montreal conference with Dr. Markham and Greg Haber, actually the Toronto conference by Drs. Markham and Haber. And, they were looking at that point in time where it was one of the first introductions of cryotherapy for treating Barrett's esophagus, and it became extraordinarily interesting topic for me. And as that whole topic has evolved over time, and we've come through a variety of different treatments, despite treating Barrett's for 20 years now, we still don't really have a consensus or an adequate method for the follow-up of Barrett's patients post endoscopic eradication therapy. And that's primarily one of the reasons why we looked into this this topic. What would be the best way for doing surveillance in patients post endoscopic eradication therapy? Unfortunately, we can't leave these patients alone because we know that that there is recurrence of both intestinal metaplasia and dysplasia, and forceps biopsy, has been, sort of the gold standard, but we don't know the best way. And with the introduction of WATS3d, approximately almost 10 years ago now, that whole method has become very robust, and the manufacturer itself, or the lab, CDX Diagnostics in New York, had put together a couple of registries to collect data on patients with Barrett's and doing surveillance, and they looked specifically at a group of patients that had endoscopic eradication therapy. And these two registries, number 706 and number 806, they put together the data on patients who had endoscopic eradication therapy. There were over 1,100 patients, 1,114 patients that had endoscopic eradication therapy at some point in time, and over 1,700 procedures, and asked us to look at the data to compile it and see what the whether or not WATS had a benefit, an adjunctive benefit, to the use of both forceps biopsy and WATS3d. And you know, our data was a registry design, but the findings, I think, were pretty significant. And we found that as an adjunct to forceps biopsy in detection of intestinal metaplasia post endoscopic eradication therapy, the adjunctive yield was 52.5%, and the adjunctive yield for finding dysplasia was 91.5%. But one of the things that was, I think, outstanding to me with this is that, you know, WATS is a brush biopsy technique. It's an abrasive brush biopsy technique, and we can get into it a little bit more. But you know, one of the obvious reasons for using WATS is that it covers more surface area, and you would expect, with it covering more surface area, that it has distinct advantages in doing surveillance in patients with longer segment Barrett's, because we're covering more tissue. Forceps biopsy in somebody with long segment Barrett's, you may only be picking up 1% or 2% of the tissue at risk, whereas WATS covers much more surface area. But the interesting part in our study was that the highest adjunctive yield for detection of intestinal metaplasia at 260% actually occurred in patients without any endoscopic evidence of recurrent Barrett's whatsoever, and that was pretty big. Neil, you know, I know you're experienced in this, and Matt, you know, we go back to the days of photodynamic therapy and things for treatment of Barrett's, and you know, when you do surveillance in somebody post EET, a lot of times the recurrences that happen in the body of the esophagus are pretty obvious. You know, you usually see a little nodule or something like that, and you know, it's not too hard to detect somebody having a recurrence there. But where the battleground really is, the battleground is at the GE junction and in the cardia. And our data, I think, shows, and I've, you know, felt this about WATS for a long time, is I don't think there's any better technique for picking up dysplasia or intestinal metaplasia in the cardia of the esophagus and GE junction. And this method really shined. It gave us a great deal of insight with picking up residual intestinal metaplasia at the GE junction. You know, you can say, you know, well, you just, you know, well, maybe you were picking up intestinal metaplasia in the cardia. What difference does that make? But it does make a difference. It makes a big difference. In addition to that, we actually had 29 patients who were found to have high-grade dysplasia and esophageal adenocarcinoma detected by WATS, where forceps biopsy missed 11 of them. Okay, and 7 of them, they didn't even detect intestinal metaplasia. So I think that that the technique really proved itself in this paper.
Appreciate that's perfect. That's a great summary of the paper and the findings, and we'll get more into the details of what the significance is and how this might change practice patterns, but also what's innovative about it. I guess I always ask this question on all these author interviews is, if I can have 3 key points, can come from any of the 3 of you, but or 1 from each of you, what are 3 take-home points from this research study that people should have?
I'll jump in.
Ahead,
give Scott a little bit of a breather. And so I think the major thing, I mean, it's the key point is it's different for people who don't use WATS, and then there's another point to people who use WATS. I mean, for the people who don't use WATS, it's just another reason to use it. It's very complementary. It really impacts upon your treatment. If you're just surveying somebody and you don't do WATS, and it happened to be that one of those patients, the WATS would have shown high-grade dysplasia or even intramucosal carcinoma, you could be going down the wrong path and wind up with an interval adenocarcinoma in that patient you have under surveillance. Especially nowadays, where if it's a short segment Barrett's esophagus, the new guidelines are don't do them in 3 years, let them go for 5 years. Well, if you happen to miss that high-grade dysplasia intramucosal carcinoma, now you have an interval esophageal cancer on your hands when they come back at 5 years or even 3 years. So that's for the doc who's not utilizing WATS and is just in a hurry to get done. For the people who use the WATS, and I was one of these guys that said, oh, I ablated this, short segment or long segment Barrett's so well, why do I have to? And I'm taking a whole bunch of biopsies and I can see everything that's squamous. I'm using my narrow band. I'm not seeing any islands of columnar lining here, and the junction is looking good. The Neo-Z line's actually looking pretty good. So maybe I'll just skip doing the brushings, because although it only takes a couple of minutes, it is a couple of minutes in a busy day that sometimes you want to get back. And I can, this paper goes to that point that when you have eradicated somebody, as Scott has pointed out, you can't stop following them. About 8% of patients per year can develop recurrent intestinal metaplasia, and then even dysplasia, 1 to 2% of patients. And so you can't let your guard down, because if this patient originally had low-grade or especially high-grade dysplasia, and you're taking a shortcut and you're just doing your biopsies and you say, there's nothing there, and you let them go, now you might extend it. With the high grades, you extend them, from 3 months to 6 months to a year. And the low grades, from a year, maybe you're inclined to let them wait a little bit longer. Well, if the brush biopsy, the WATS analysis showed that they had recurrent or residual low grade or high grade, you want to know about that then and do a better job and take care of it rather than wait another year or 2. That's my 1 and 2 points.
I'll add a couple of years. So I think what we're all saying is, number one, WATS3d as an adjunct to forceps biopsies increases the diagnostic yield of intestinal metaplasia and dysplasia in patients post-eradication therapy. I mean, that's the obvious take-home point from this paper. The second take-home point is that specifically increases the diagnostic yield of those lesions in a group that are difficult to detect. And that's what Scott just pointed out. And that is patients who don't have obvious residual Barrett's, but those who have tiny bits of residual Barrett's left around the distal esophagus GEJ region, an often difficult area to survey, and also an area that is common for recurrence, both in intestinal metaplasia and dysplasia, and in the development of cancer in patients post-eradication therapy. Those are 2 key points. As a pathologist, I'll throw in a third, and it's not necessarily related to this paper, but it's related to the technique in general. WATS is a 3-tiered diagnostic platform. The first tier is, as Scott mentioned, the hard, bristly, deep brush, which requires more tissue, but also deep tissue as deep as forceps biopsies, which is very different from the old-time conventional cytology brushes. So we're getting with the Watts brush, deep tissue and more tissue. But then there's the computer aspect, and there's two aspects to the computer technology, and that's the second and third tiers, if you will, of the Watts platform, and that is EDF imaging, extended depth of field imaging of the tissue, and that's followed by artificial intelligence neural network analysis of the tissue, which is designed to recognize intestinal metaplasia and dysplasia and present that to the pathologist in 3D-like images. And what this does, I won't take too much of your time because I know this is mainly a gastroenterology audience, but what this does is make our job easier. We don't miss as many things, and the things we see are much crisper, clearer, and have more clarity. And so I have found personally that making diagnoses of intestinal metaplasia and dysplasia in particular are easier. That has been borne out in one inter-observer study that was done utilizing in-house CDX-employed pathologists. Just recently, we completed a inter-observer study with 5 non-industry academic GI pathologists in the USA evaluating digitalized images of Watts samples, negative and positive for dysplasia, low and high grade in cancer. The results were quite amazing. Kappa values all over 0.9, which is in the very excellent range. And this data will be presented hopefully at the upcoming DDW meeting if it's accepted for publication. But it is a data that we are putting together as a full paper as we speak. So I just wanted to highlight that from the pathology perspective, it is, in my opinion, an advance over prior and conventional forceps biopsies.
Yeah, I think that's an important point. You know, innovation is a big part of what we're trying to focus on in this journal. So it's not just catered for endoscopists like us, but I think it's really catered for anybody in the GI space, whether it's pathologists, surgeons, bench scientists, really what the purpose of this journal is. And I think you pointed out that question that I always like to ask, which is what's innovative? So this computer assistance, which we're seeing more and more of as people are getting hot on AI, seems to be at least invading the pathology space to some degree. Is that correct?
Yeah, I mean, the innovation is number one, the brush, and number two, the computer artificial intelligence. Remember that the artificial intelligence or the neural network, a neural network is essentially a computerized brain which has been trained to recognize a type of lesion by presenting that lesion to it many thousands of times over so it can learn the individual features. The utilization of this technology is not done by, the diagnoses are not done by the computer. The analysis of the slides, the analysis of the tissue, and the ranking of tissue according to how atypical they are is what the computer does and presents that to the pathologist, who then signs out a case utilizing both the slides and the computer digitalized images that have gone through the neural network. And it's the pathologist who makes the diagnosis. Either way, that's new technology.
Yeah.
Just a little background on that, actually, which may be interesting in this format rather than reading it in a journal. The fellow that developed this technique to begin with, Mark Rutenberg, a very interesting guy who actually was part of the Star Wars program. And his job in the Star Wars program was designing a computer algorithm that could detect the difference between a true nuclear warhead and what was a decoy. And in working at this, it just so turns out that Mark was also a cell biologist. And he says, this information has got to be able to be applied to medicine. And the first thing he did in looking at that was actually looking at the Pap smear. And what he was able to do was take the 200 or so most likely cells to be abnormal and put them in front of the pathologist rather than the pathologist having to sift through 50,000 cells. And it pretty much revolutionized the pap smear. And his next project with this was looking at Barrett's esophagus. Was, gee, we have to have a better way of being able to help out the pathologist. And he applied that to Barrett's, in a very similar way that they were using in the pap smear. But in addition, they did something even more advanced with that. And as you know, if you're looking through a microscope and you're looking at high powered images, what you're seeing in focus is very, very clear, but 3 microns away is out of focus, and you can't make detail of that. Well, what this system does is it incrementally takes 3 micron images, okay, and in sharp focus, and then the AI and the neural network, it puts this all together and assembles it in 3 dimensions, so that the pathologist can now look at a gland that's 150 microns thick and is in sharp focus. And
all of it is in sharp focus, not just one 3 micron section. That's the EDF sectioning, extended depth of field analysis. And that's the part of the computer system that creates 3D-like images where a pathologist can see all the cells in that clump of cells and not just one tissue section as we're used to seeing it in forceps biopsies. So Scott is spot on.
I've been there. I've seen it in action. So it's pretty good.
And another similar space where we see some of that technology that's really kind of coming from astronomy and satellites and space tech is CLE. So CLE is kind of similar, right? So Mauna Kea, some of that technology for CLE was also originally made, my understanding is, more for telescopes and things like that with laser refraction, and they made it essentially the opposite in the most smallest focused areas. So it's great to see how the tech catches up and kind of changes the things that we do. I guess this brings me to the question around research and the why, right? So we've talked about what the article is. We've talked about how you guys executed the research and the meaningful nature of the research and what people can take home. But, as we kind of get into the conclusion of this author interview, I always like to find out from the perspective of the authors, why take part in clinical research, what other people should see in the value for that. So, before you answer, I guess I can say for myself, my interest in doing clinical research is I feel like I need to keep myself in check. So I want to give the best possible service for my patients. So I study everything I do. Most of the time, the recorder's on in the room. I'm recording my own videos of the surgeries I'm doing. I'm keeping track of all the data. It's usually part of a number of different research studies. And it keeps me in check, keeps me sharp. I feel like I'm contributing to the work for my patients, not just the now of what I'm doing, but I'll modify my behavior so I can get better outcomes for them. And it applies to the clinical space for me. Maybe for the 3 of you, if you could go around and kind of tell me, what does it mean to you? So maybe in the context of this particular research for this article, or in the totality of your clinical careers.
Oh, sure. I can start with that. Or Scott, you want to start?
Go ahead, Rob.
Sure. Well, for me, I'm a little bit of a different type of pathologist because I come from a clinical surgical background. I originally did a residency in general surgery before switching into pathology. And the why I'm saying that is because that decision was made purely on the basis of a desire to do something more important. I shouldn't say more important in a different way in medicine. And that would be original research and making discoveries that would make an impact in patients' lives, rather than simply performing clinical care, which of course we know is important as well. But for me, it was seeking answers to questions that we didn't know the answers to was what drove me into medicine, coming from a physics background and then a clinical surgical background. So I've always had a fascination with trying to answer scientific questions, but in a clinically important fashion. And that's the key difference, I think, with maybe some of my other pathology colleagues. a lot of pathology research is done purely in pathology, which is very important as well. I chose a path to do research in pathology that would have clinical impact. And so every single project I do, I ask the question, is this going to help solve an important clinical question? And this one particular study on WATS and endoscopic ablation patients, I think satisfies that criteria from my own point of view.
Yeah, from my perspective, Neil, I guess I've been introduced at DDW by Tony Infantolino from Thomas Jefferson. I was introduced him saying Scott's an academic physician who just happens to have spent his entire career in private practice. And yeah, that's that's what I've done. And as I said, I had the bug lit in 1997 at that Toronto conference when I said, oh my God, we might be able to treat Barrett's esophagus. That's a real interesting thing. And, as part of that, I really wanted to make a difference. And in making a difference to your patients, sometimes engaging in clinical research is important and extremely rewarding, and it's extremely helpful too to the profession as a whole and to your patients. And I think that you can partner in a variety of different ways with industry to be able to carry out research. Most of what we're seeing in this field has, even if it was initiated in the academic setting, it has to be proven. It has to be proven in the community setting. It's not good enough for it to just be carried out in academic centers. And I think one of the first papers that I was involved in was a community registry paper that we did with Barex Medical. And in doing this with Bill Lyday, myself, and my former partner Doug Cooperman, and a few other co-authors, it's become one of the most cited papers in Barrett's world, because here it was the community setting, the docs out in the community that were proving that we could do this technique as good, if not better, than what was being performed in the academic world. And that's kind of been very rewarding to myself. Also, participation in the Barrett's registry was a very rewarding thing, and as is this. And working with the caliber of my two co-authors here, Rob and Matt, was just a great experience. And I appreciate the opportunity to have worked with the two of them. I think that had two of the finest co-authors I could possibly have imagined. Thank you, guys.
Amazing.
I got my 5 minutes or so. So with that finished, Scott, I know what your next career should be. It's called politics. In fact, I'm getting an image here where you're sitting. It's like the White House. I'm telling you. Guys, you're perfect for the part.
But the difference is that Scott speaks the truth.
Yes, yeah, that's right. And we actually
that's the only thing that just follows me there.
You have some
Not good for politics, Scott.
I'm sure you're aware of the congressman we have up here that basically lied about his work history, his educational history, et cetera. So we might have an opening pretty soon,
Yeah.
Scott. So you have New York roots, I told me. So
I think that comes from my old congressional district because
yeah.
you know, Franklin Square, and
Yeah.
and back then it was actually Jack Widely that nominated me for the Naval Academy back way back when. But yeah, yeah, politics. Yeah, no, I think I'll leave that to my son.
So, Neil, to get to your question, and I'm going to use the same phrase you used. I think it is very good to keep yourself in check, and taking care of your patients, always trying to do the right thing. In today's world, gastroenterology, you can get very busy doing your endoscopies. Lots of GI guys nowadays are just that. They're endoscopists, they're not gastroenterologists. They don't have the same academic bend as Scott has maintained over the years. And it's a shame to see that. And so, yeah, whether or not you're actually involved in some trials and have publications, I think it's good for the community physician to participate somehow. And there's plenty of opportunities, whether it's pharmaceutical studies or the barracks registry in the past, the WATS3d registries. So I kind of had my introduction was I was trained to be a gastroenterologist, and I was in a way to go into private practice when North Shore called me up, and that's where I had done my internship and residency at North Shore and Memorial Sloan Kettering. And they never had a fellowship. They had fellowships in pretty much all the other subspecialties except for pulmonary and gastroenterology. So they asked me to come back. They had tried to start a program several times and it didn't work out. So they asked me to come back, and I had the unique opportunity then of starting an academic program. We developed I think I mentioned, flow cytometry lab. We had an inflammatory bowel disease lab. We had grants, fellowship, the whole bit. So I did that for 20 years. So I had that bend to my approach to patients. And so when I went into private practice after 20 years of quotes academics, I felt the void not to be doing any clinical studies. So it didn't take me long to get involved. Richard McCallum was one of my mentors, and so I could easily get involved with pharmaceutical studies. And then with my passion and interest in Barrett's esophagus, I did the flow cytometry, DNA histograms, looking for aneuploidy. And so when I went into private practice, I looked for colleagues to participate with. And luckily, I found McCallum again. I found Arvind Trindad, various companies. Barracks reached out to me because of my prior experience. VLE, I got involved in that. CLE. And so it just gives you a charge. It makes you read about things that otherwise you wouldn't read about. And it keeps you in check to do the right thing. And it's a great experience. So I would say to guys in community practice that it's very, very rewarding to be involved in clinical research in some manner, whether or not you get publications. So of course, you get your name on some papers, and that's the old medical school thrill that, oh my God, my name's in print. So it's a good thing. That's the way I would look at it.
Well, thanks, gentlemen. I'm sure that you've inspired a lot of people. I know for myself to get some time with the three of you is important. I like to have a better historical perspective and also have an understanding of, how that's led to the now, which obviously through all of your experiences and the way that you've moved the radar for Barrett's. And I think those who aren't familiar with their names should just do a quick PubMed search. I know for myself, doing a lot of Barrett's work, I've seen your names on publications many, many times before. And as far as this particular paper and research study, it has changed my overall approach as well, to be completely honest with you. So I'm using WATS religiously and adding it to my armamentum for patients I'm surveilling even post-treatment in a pretty high-risk population that I take care of here. So thank you so much for your work. Thank you for your insights. I think it'll be really helpful for people to watch this video and be inspired. And I appreciate your contributions to our premier journal.
Thank you, Neil. Thank you. Appreciate it.